Yeah, it means you're making a difference. And so as a cardiovascular care community, yeah, we're making some headway.
Dr. David Winchester, how you doing, my Gator friend?
I'm doing good.
I am excited to chat with you about some cardiology tonight. Before we jump in, I want to say hello to the 1,300 or so students that are hanging out with us. We'll hopefully have some time at the end for some Q&A after some cases. I love to start these just with a fun little conversation about how you ended up in cardiology.
How did I end up in cardiology? So in medical school, I think that the advice that I took to heart was going into third year in clinical rotations, trying to figure out what did I like better, just like big broad strokes. Did I like medical stuff or did I like surgical stuff? And so, I mean, I did the standard sorts of rotations that everybody does. I did OB-GYN, I did family med, I did internal med, I did surgery. I actually did cardiothoracic surgery as like my subspecialty sort of thing. And definitely settled on enjoying the outpatient experience and the medical management of patients more so than surgical. And that was just, that was what my interest was. And then within that, I really was drawn to cardiology. It was something, when we were reading electrocardiograms in third year, I'm like, yeah, this is really fun stuff. And, within surgery, that cardiothoracic experience I had was the most interesting time that I had on any of the surgical specialties. So I was sort of focused on cardiology at that stage.
Yeah.
Then I go into my internal medicine residency, and from there, wanted to try and keep an open mind. Thought I wanted to do some, leaning towards cardiology. But I did GI, I did hem-onc, I did a couple of other things, and nothing clicked as much. My wife likes to tell the story. Actually, at the time that I came home, probably like third day on my first cardiology rotation, and she was continually asking me, are you going to do cardiology? Are you going to do cardiology? And I was always hemming and hawing. And eventually she just said, would you just stop? You are so much happier. You are so much, you're smiling and enjoying. You're clearly, you're almost glowing when you come home from the cardiology rotation. So it's clearly what you want to do. Just stop, and just commit. So,
that's
let's listen to what your spouse says. And from that point on,
that's all you need in life. Listen to your spouse.
That's right. She knew what was up.
Talk about the training path. Students always question the time to get to become a cardiologist, and cardiology is one of the longer ones out there.
Yep. So, 4 years of med school, 3 years of internal medicine residency. There are a couple of specialized programs where you might be able to find something that combines medicine cardiology or medicine GI, but for the most part, it's 3 years of medicine, and then it's going to be 3 years of general cardiology. And then after that, I've got a slide to talk a little bit about, subspecialty careers within cardiology. You can go on and do additional fellowships pretty much for as long as you want to. I actually had one of my trainees who came, I run a cardiovascular imaging fellowship in Gainesville, and I had a guy who came and did it with me. And then afterwards, he went back and did a peripheral vascular fellowship, and then he went on to do just a regular interventional fellowship. And so he just, more power to him. He enjoyed all the training, but he's finishing up that interventional fellowship now. And
at some point the bank wants their money back, so make some money.
Yeah. But so for the general cardiology is 3 years, and then a lot of people choose subspecialty. I would say 80% choose some sort of subspecialty training, which is going to add on at least 1 or 2 years. It can be a long path. But in the end, I think that the advice that I would always give any student is, if you're passionate about it and you really enjoy it, put the time in, and then you get to do that for the rest of the time.
Yeah.
And so, it can be a long time. But yeah, it's worth it if it's what you enjoy doing.
Yeah, very cool. Talk about bread and butter, and for the students who may have not heard that term before, bread and butter. What are the common things that you're seeing day in and day out? The quote unquote boring stuff that you have to love to come home with that glow.
No, you're right, and I think that's an important thing to try and identify during third year if you can, right? So the thing that I said at first about is it medicine or surgery, I think that's a good question, basic question to ask. But then another is like if you start to hone in on something, think about that one thing that that specialty sees a lot of, that is going to be your bread and butter, the common stuff, and can you tolerate that? Because there are some of those things that you might like the general pulmonary. Like I really enjoyed ICU and critical care. Did not have any desire to manage chronic lung disease. Yeah, none whatsoever. And so I'm just like, oh, no. Yeah. And so, that cardiology was another, was a different one. So, what is it in cardiology? I'm going to talk a little bit about it in more depth from a disease state perspective, but from a patient presentation perspective, it's going to be number one is chest pain. Number two is going to be shortness of breath. And then if you're in the subspecialties, you might have some, a little bit of a different take on things. So electrophysiology is a group of cardiologists that primarily deals with heart rhythm problems. And so palpitations, fainting spells, so they're going to be common things that you see as an electrophysiologist.
How often do those workups for the chest pain, the shortness of breath actually lead to a cardiac issue?
It's hard for me to put a number on it because it depends a lot on the population you're dealing with. Yeah. Right. So with me, my particular specialty or my particular practice is in a veterans hospital where I'm predominantly dealing with people that have existing diagnoses of coronary disease, heart failure, those sorts of things. Yep. So it's a bit of more of a higher likelihood of finding things than if I was even if I was predominantly over on our university side, I would probably see less of it. Yeah. But I think that's okay. And I think one of the things that I've become pretty comfortable with that is really important to patients is being able to have an honest conversation about, well, I didn't find anything wrong with your heart. Here are some other things that could be going on. And, and the good news is I understand how you feel. I appreciate how you feel. I acknowledge how you feel. What you are feeling is not, to the best of my capacity to determine, something dangerous that's going to kill you. Right. So let's focus on how can we make you comfortable with that? How can we get you doing what makes you happy and makes you healthy? Yeah. And so that's a conversation that I do end up spending a lot of time having, because there's only so much that the tests can do. There's only so much that they can diagnose. And if they come back normal, that doesn't mean people don't feel bad. Yeah. I think that's a really important thing. It's not just for cardiology. That's for anything. There's there's a limited amount of what we can really diagnose based on our tests. Yeah.
I think that's doctoring 101 is empathy and reassurance. For all of your patients.
Yeah, absolutely.
Talk about right now in the current climate that we're in with COVID. I think we do know that COVID has some cardiac manifestations. How much do you think we're going to be seeing in the future for students watching this in the future when they become practicing cardiologists? Are we going to be dealing with COVID sequelae for a long time, or is this just for a little bit we're going to have to worry about it?
So I was just reading a paper today actually about COVID complications and the biomarkers that we use to diagnose heart attacks, which, in a process like COVID that causes systemic inflammation, everything in the body gets messed up to some degree. It's very common to see these biomarkers elevated, and we're still doing our best to sort of figure out, like, what does that really mean? And pretty much universally, when those biomarkers are elevated, it means people are at higher risk of having bad things happen to them down the road. The question is, can I do anything about that? Are there medicines I can give? Are there treatment strategies I can employ? Are there specific follow-ups that we can do? And right now, we don't have much of any of that. Yeah. And so there's a lot of interest in doing some of the other imaging techniques that I'm going to touch on, and some of which I do, trying to identify these people again that are at high risk. But one of the things that I'm always focused on, in practical terms, is that we can do a million different things to identify people that are at high risk. But if I can't do anything about it, I'm not very enthusiastic about tracking that kind of stuff down. So what does it mean for the future? We are certainly seeing a lot of this, biomarker elevation, inflammation of the heart tissue, and there are some people that seem to be having sort of like late complications of that. The weeks after or months after are having an event, and then it's like, well, was that really related to the COVID or not? And it's hard to track. It's hard to really, prove what's going on. I think that's still very much a subject open for debate.
Yeah. Is it fun? Obviously, the seriousness of COVID, we understand, but is it a fun time to be a cardiologist, to see this new thing and get to study it and learn it and figure out what's going on?
Yeah, I mean, I to a certain extent, I think anytime there's there's something new, it is intriguing. I think that's physicians. Most of us anyway are scientists at heart, to some degree, and are interested in learning new things. Yeah. For me personally, the thing that I'm doing with this is I've actually got a grant that was funded to evaluate, not at that granular sort of patient level, but it's a little bit bigger, of what is COVID doing to other cardiovascular care. So when this hit in February, March, April of last year, there was a big question as to whether or not that was going to increase or decrease other cardiac events.
Yeah.
And the one that some of my heart failure colleagues were particularly concerned about is, if we shut down all the clinics and none of our heart failure patients can come in to see us in clinic, yep, they're all going to go to the hospital. And I think that's a perfectly reasonable hypothesis. It has, though, thus far turned out to not necessarily be the case.
Yep.
But the problem is that there are also signals that there are increased out-of-hospital deaths. Yep. And so the concern may be that they were right, but it didn't quite manifest the way that we thought it would. Because I actually have personally spoken to patients who, on the phone, I'm like, you don't sound good. You sound short of breath. You should come to the hospital. And they're like, nope.
No, not getting COVID. Yeah.
No, not going to do it. I don't want to be anywhere near you guys.
Yeah.
And I mean, I understand the concern. I understand the apprehension. But that consistently has been shown. There have been several studies now. And it's one thing when it's like heart failure and people are like, maybe I'll just figure it out and I'll take a couple extra pills at home. But the really concerning thing is that there was a drop in heart attacks. There was a drop in admissions for strokes. And there's no biological reason for that.
Yeah, you would assume epidemiologically that the numbers are the same. They just aren't showing up in the hospital. They're just dying at home.
Exactly. That's what the data is. And so it's easy to show that we had this many MIs and then it went down. It's harder because nobody collects the data to prove that people are dying at home. But the couple of papers that I've seen that have tried to evaluate that, that's what they've shown.
Yeah. Interesting. All right, let's go ahead and jump into your slideshow. Get to hear some cases, and then hopefully we'll have some time for some Q&A at the end.
Yeah, so let me see if I can get this up and running one more time here. All right.
Perfect.
So, so I really just included one case up front here because I wasn't quite sure how much to do with that and how much to just sort of talk and go on about life and career as a cardiologist. So I came up with this just as sort of your average cardiology patient. So this is, like you said, the bread and butter. This is the sort of thing that I would see every day in my clinical practice. You know, a man in his 60s, he comes into clinic, he's got a little bit of dyspnea, which is shortness of breath. He's got some occasional discomfort in his chest. Looking through his medical history, he's probably got a history of coronary disease. He might have had a percutaneous coronary intervention, which is a coronary stent. And he might have had that put into one of his arteries, in this case for a heart attack. Maybe he's got some diabetes, which is DM2. Hypertension is high blood pressure. COPD, chronic obstructive pulmonary disease. Obesity, and then heart failure with preserved ejection fraction. This is sort of, I put those in there on purpose to, if you're not familiar with those abbreviations, that's what those sorts of things are. His social history, so he has a 50-pack year history of smoking. He continues to smoke about a pack per day. And he's actually not taking too many medications. His diabetes is controlled with diet at present. He's taking an aspirin, which is the ASA, atorvastatin, cholesterol medication, and some lisinopril for his high blood pressure. And so I'm going to circle back to that at the end, but that's sort of the average person. That's what I see with my bread and butter, is people with this degree of chronic illness and these sorts of complaints. So one of the conditions that this patient has is coronary artery disease. And this is a chronic illness that's got an acute phase to it. So it tends to be a process where the arteries of the heart have plaque that builds up in the walls of those arteries. And that plaque shows up there. It's predominantly an inflammatory process, right? So it's driven a little bit by your cholesterol. It's driven a little bit by your genetic profile. But it's driven by your high blood pressure. It's driven by smoking, and all these things coalesce to have this plaque that's made up of cholesterol and white blood cells and other sorts of things in these arteries that can either progressively cause narrowing of the arteries, and if it does that and it limits blood flow, that may manifest as something we call angina. Which is the classic chest discomfort that patients get with this disease, or if this plaque ruptures open, right? So it's stressing the vessel wall, and if there's damage that causes that vessel to rupture, the contents are very prothrombotic. So they cause clots to form, and that blocks off the artery, and that's what causes a heart attack. So a couple of different manifestations of this, but this is easily one of the most common diseases that I see, coronary artery disease.
Yeah. Lots of smoking and too much fried foods.
Yeah, and it's an all too common illness for a variety of reasons, but smoking and diet and lack of exercise all contribute to it for sure.
Yeah.
Next up is hypertension, which arguably may be even more common than coronary artery disease. And so this is the medical name for high blood pressure. And so as arteries age, they become stiff. They generate a higher pressure within the lumen, within the opening of the blood vessels. that's part of it. There are neurohormonal controls, elements to this disease as well. But the bottom line is that a lot of people have high blood pressure, and it damages all the vascular beds. So it contributes to the development of coronary disease, but also to peripheral arterial disease, to disease in the carotids that can lead to stroke. And so hypertension is something that's very, very common, and unfortunately not very well controlled. Something like half of people with high blood pressure don't have adequate control of their blood pressure, despite the fact that we've got like 6 different classes of medications. Each one has got several medications within to treat high blood pressure. So a very common problem. Heart failure is another very common thing that I see. Heart failure is very, very complicated. There's a lot of elements to it. It's something that gets oversimplified both in the lay press and honestly even within the medical community. People lump a whole bunch of things together as heart failure that's not necessarily heart failure. But the bottom line is that if your heart either doesn't squeeze well, so the pump function is bad, or if it doesn't relax well and it can't accommodate blood returning to be pumped back out again, either of those conditions can lead to this state where you have increased pressure within the heart, and that pressure gets transmitted backwards through the circulatory system. So it kind of sort of backs up the system and causes the other vascular beds to have to experience this higher pressure. And so if you feel that in the pulmonary beds, then you start to get this fluid in and around the lungs, we call pulmonary edema. Or you can get it back on the right side of the body, and then the venous system and everything that drains into the right side of the body starts to swell. So that's where you get these distended neck veins. You get swelling in the abdomen. We call that ascites, from fluid filling the abdominal space, swelling in the legs, or edema. And so this is a very uncomfortable condition for a lot of people. And we have to manage it in a variety of different ways, depending on what the underlying problem is. Is it a squeezing problem? Is it a relaxing problem? Is the blood pressure an element to it? Is the coronary disease an element to it? So there's a lot of stuff that goes into it. Switching gears a little bit, atrial fibrillation I picked out as an example of one of the many rhythm problems that we see. So atrial fibrillation, just as a very brief anatomy lesson here. So this is a picture of a heart with 4 chambers. This is your right atrium, your right ventricle, left atrium, left ventricle. Everything's reversed when you do these sorts of anatomic presentations. And so normally the way the heart's electrical system works is it will cause the atria to squeeze, which fill these ventricles. These are then the major pumping chambers that pump blood out these big blood vessels up here to the lungs and to the heart. And so they go lub-dub, lub-dub. That's what gives you your heartbeat sound, is these chambers squeezing. Atrial fibrillation is a very common rhythm problem where the top chambers, instead of squeezing in sequence, they start to fibrillate. They quiver like this. And what that leads to is a very irregular rhythm. It's got no particular pattern to it. And that can cause symptoms of a variety of different types, so that people might feel palpitations or a fluttering sensation in their chest. It might make them short of breath. It might contribute to heart failure or some of these other sorts of things, which then can make people have edema. A number of these things are interrelated. But this is a very common rhythm problem that I see, particularly in older patients. And I won't even touch on management of this, because there's about 1 billion different things you can do to manage this. But it is a very common problem for us.
A lot of students love to learn EKG, reading EKGs. What is I know when I went through the process, Dubin's was like the gold standard to easily learn how to read EKGs. What are your thoughts on a good book that pre-meds can pick up to start learning this stuff?
Honestly, I mean, Dubin is still an excellent choice, but I have to admit that there are a number of really good websites that have got some great collections of stuff out there that are done by docs that just want to share what's going on.
Yep.
And one that I've actually been following on Twitter lately is Learn the Heart. And they do, I forget if it's daily ECGs, but they do a lot of them, and they're really pretty good. So that's a one that comes to mind as a pretty good source. I'm blanking on the names of a couple of them, but there are some others that are done by not necessarily cardiologists either. Sometimes they're ER docs or ICU docs. There are a lot of people that read ECGs. But yeah, I would not be afraid to search the web for other sorts of things and buyer beware. But if you can get the vibe for what's a legit site and what isn't. And I think there's a fair amount out there that you can basically get for free.
Yeah. Cool. Learn the Heart has some new followers now.
Yeah. And I don't own them or I don't have any interest in them. I've pulled a few interesting things myself to then reteach to other people. So I give them credit for that.
Their website gets a ton of traffic. I'm checking it out now with my analytics. They're doing pretty well. That's
all right, very good. So stroke is another one that I included as a cardiovascular disease. I personally don't do a whole lot of stroke care, but there are some cardiologists who this is a big part of what they do. And so it is a vascular condition. It's where, like I talked about heart attacks in the coronary arteries before, the cerebral arteries, if they get blocked for one reason or another, you can damage the brain if it doesn't get enough blood flow, enough oxygen. So these are examples of MRIs of patients who had a stroke here in the middle cerebral artery, which supplies this middle part of the brain here. And we use a lot of the same sorts of medications and approaches to stroke care as we do to coronary care, reducing cholesterol, a certain amount of blood thinners, and on occasion we do some of the same, some similar techniques in terms of interventional procedures that I'm going to touch on in a minute. All right, so I wanted to throw in just a couple of random facts that I think are important things for anybody really to know about cardiovascular disease, just in case this comes up in conversation with somebody else, somebody else in the public. Number one is that heart disease is the number one killer of women. And this is something that amazingly a lot of people don't know and a lot of women don't know.
Yeah.
There are a lot of other things out there that get a lot more press, that get a lot more attention, and particularly in the lay media. Unfortunately, heart disease just doesn't get the attention that it does. But it's the number one killer of women. And it's really important to be thinking about if you're a physician taking care of women, because in addition to it being very common, women have unique risk factors for cardiovascular disease that men don't have. Some of that relates to pregnancy. Some of that relates to the hormonal changes of menopause. There's a whole bunch of things that it's an emerging area where there are truly things about women that make them uniquely at risk for heart disease. So I just wanted to briefly touch on that, make sure everybody was aware of it, and make sure to tell your moms and sisters about it.
Do you think this is potentially a kind of a side effect of oral contraceptive? Adding a lot of hormonal not issues, but hormonal differences into normal physiology?
That question has come, back and forth. There was a time when the very rudimentary understanding or the rudimentary thought process about this was that estrogen was protective, and that women should continue to take hormone replacement therapy specifically for the risk, to reduce their risk of heart attack. And when I was in medical school, the Women's Health Initiative study was a big landmark trial. Every once in a while, these trials come along to just like blow conventional wisdom out of the water. And it just absolutely destroyed the notion that hormonal replacement therapy was good for women.
Yeah.
So the element, the component of this that's attributable to oral contraceptives, I don't think is that substantial. But then again, we used to think that women ought to take estrogen forever in order to prevent heart attacks. So.
Yeah, my other kind of assumption or guess, layperson's guess is that because symptoms are different in men and women, and historically, unfortunately, women aren't believed as much as men, that their symptoms are not followed up on as they should be, and so they're getting worse.
Yeah, and that's another interesting point because on the one hand, women tend to use different vocabulary.
Yeah. And
this has to do with we're all experiencing similar things with our bodies, but we will use different words for it, right? So I'll have patients who come in and they're having angina, and I'll have 5 different people with angina, but they'd all describe it differently. Yeah. And sometimes it's like, oh, it's a pressure, or it's it's funny when I talk to some patients, I'm like, oh, so I heard you were having some chest pain. They're like, I do not have any chest pain. I have chest pressure. It's like, oh, I'm very sorry. I didn't realize that we were that concerned. But I'm making that distinction. But yeah, so sometimes it may be partially that. Maybe there's some vocabulary differences in how people are using words to describe the same sorts of things. But I do think it's also important to note that chest pain is still the most common in both men and women. But like you said, it tends to be ignored or downplayed in women as compared to men. So a woman comes in and says, I have chest pain. Take the case that I said at the beginning. That was a 67-year-old woman with a 50-pack-year history of smoking and diabetes and hypertension who comes in with chest pain. And the same one as the man is more likely to get tested for heart disease.
Yeah.
And that's got to do with misunderstanding of doctors. Some of it may have to do with, inadvertent or blatant sexism. It's hard to say, in an individual case what's driving these sorts of things, but there certainly are some disparities because for a long time people thought it was a disease of men, and it's not.
Yep. Well, now we have 1,400 future doctors who know that it's not.
That's right. Very important.
Women in the future.
That's right. Okay. Number 2, a lot of heart disease is actually preventable. And I run into a lot of patients that are like, oh, well, my dad had a heart attack, so I'm going to have a heart attack. Well, that's not the case. And there is so much that we could be doing as a population to improve our cardiovascular health. And this is just one prevention study. It's getting a little old now. I might have to update this for a newer reference, but this is a paper from the Journal of the American Medical Association, and it was several thousand patient cohorts. So it's a big group of people that were followed for 15 years. And basically they tracked these people and they said, how well are you exercising, not smoking, keeping your blood pressure under control, keeping your blood sugar under control, keeping your cholesterol under control, all these sorts of things. So it's seven different health metrics. And if you look over here, what this graph says is that at 15 years, if you were doing all the healthy things, your risk of dying was less than 10%. But if you were doing none of the healthy things, your risk of dying was over 30%. So that's a phenomenal gap between ideal cardiovascular health and worst cardiovascular health. But most of this is within your control, right? Understandably, there are factors that make things difficult for some people. As an example, I used to do a clinic out in a rural part of Florida where there's no gym. You can't you want people to exercise. Like, they can't go to the gym because there is no gym. Like, if they want to go to the gym, they have to drive an hour back into town into Gainesville, right? So then it's, how do you help them come up with a way to exercise?
Yeah.
Well, maybe they're one of the people that's lucky enough to have some land out there, so you can, talk to them about, regular walking or finding some other outdoor activities to do. But Florida's hot in the summer too. Anyway, so some of these things are difficult or more challenging for some people than others, but there's a lot of heart disease where risk factors are not even close to being controlled.
Yep.
The last is that cardiovascular outcomes vary a lot based on race and sex. Some of this may be due to structural racism, structural sexism sorts of things. Some of it may be due to genetic profiles of groups, right? So depending on what part of the world your family came from, you may carry a genetic profile that actually is more favorable or less favorable. As an example, Southeast Asian, Indian subcontinent, there are some very, very, very high risk groups of people there that are genetically linked, where people will have early onset cardiovascular disease in their 30s. And so some of it is that, but then some of it in America, I didn't include a whole bunch of it here because I wanted to just sort of make the point quickly. But, you can also see where if you take people admitted at the hospital with heart attacks, and more women die than men. People that are African American are more likely to die than Caucasians, for the same condition. So some of this is, broad strokes that I've presented here, but then also there are disparities in care that result in worse outcomes for some groups. Yeah. So these are important things that we as a cardiovascular community, but medicine as a whole, needs to keep this in mind, because it's probably true in just about every specialty to some degree. Okay, so I can pause there. We're at 42.
Yeah.
And I don't want to go too terribly long into this, but I did have a couple of slides that I just wanted to briefly introduce, like what I do as a cardiologist. Okay. If that's good.
Yeah, and for you listening, go ahead and start raising your hand, and we can start bringing some people in a second to ask some questions. All
right. So I briefly want to mention, because some people do get this confused, a cardiologist is not a cardiac surgeon. Yep. There is some overlap now where there are some people doing similar sorts of things, but I'm trained in medicine and then went on to do cardiology, and then there's surgery, and they just do different sorts of things. So I'm a cardiologist, not a cardiac surgeon. What do I do as a cardiologist? Number one is clinical care, taking care of patients, seeing them in the clinic, seeing them in the hospital, seeing them in the intensive care unit. There's an awful lot of interface with patients, talking with patients, getting their history, understanding what's going on with them. So that's a lot of what I do. We mentioned electrocardiograms. So this is probably one of the most basic tests that we do, aside from just using a stethoscope to listen to the heart. But we do an awful lot of these.
I have to ask, are you team EKG or team ECG?
ECG.
Oh, man.
Yeah. I don't know. I don't really care. It doesn't bug me, but I'm going to say ECG because I speak English, not German. but yeah, I don't know. There are some people out there that really get upset about that. I don't really care.
Yeah. All right.
Echocardiograms. So I'm a non-invasive doctor. This is one of the things that I read an awful lot of. This is the same technology that we use to do ultrasound for pregnancy. We're just looking at the heart, and we watch the heart move, and we get to see an awful lot with this test. It's a very useful test to tell us about the structure of the heart, the function of the valves, those sorts of things. Stress test. This is an example of what a nuclear stress test looks like. This is a test where we give somebody a radioactive injection on purpose. That radiation goes to the heart, where it then is emitted, and we watch the photons as they come off the heart, and we generate these pictures to figure out where that tracer went to, and more specifically where it didn't go to look for areas of the heart that are maybe not getting as much blood flow as we would like. More modern technology. So yeah, for what it's worth, this is echo and nuclear. These are circa 1970s. Yeah. CT and MRI have become much more popular in the 90s to 2000s. But we actually have CT scanners now that are fast enough that we can image the heart while it's in motion. And MRI does some absolutely exquisite picture taking, again, for structure and function of the heart. The CT we use a lot more for looking at blockages in the coronary arteries. So this is actually a 3D model where you can see the coronary arteries, and you can use this to look for blockages. I mentioned coronary stenting, and this is an example of just so if you've got a coronary artery with that atherosclerosis, that plaque buildup in here, we're basically able to thread small metallic structures into those vessels and open them back up. We just put this is a balloon on this catheter here. There's this stent is on top of it. We maneuver that into the coronary artery. We expand the balloon, and all of a sudden, it pushes this plaque out of the way. So that's something that we do to restore flow in the setting of a heart attack. It's also very useful for improving symptoms in people with chronic blockages. But important to note that it does not improve outcomes. It doesn't make people live longer if you've got a chronic blockage. It does if you're having a heart attack. Nowadays, we're actually stealing some of the cardiac surgeon's work, and we are putting in valves percutaneously, right? So when I say percutaneous, I mean like we put a needle down in the leg, in the femoral artery, and we actually put one of these valve structures and replace your aortic valve, put it in place of a stenotic aortic valve. So a very rapidly growing area of cardiology.
Does the percutaneous, like if you do a bicuspid valve replacement, does the percutaneous still have the same risk of like, what do you call that? Dissection, the aortic dissection?
Yeah, so particularly with bicuspid valves, the problem is that the valve is affected, but then the aorta is affected separately. So if you replace the valve in a bicuspid, you don't not necessarily resolve the underlying aortic issue. So people are still at risk for that.
Yeah, interesting.
Electrophysiology, this is a potentially very complicated field. This is an example of a procedure being done on somebody where they've got 1, 2, 3, 4, 5, 6 different catheters in their heart, mapping the electrical signal from a variety of different locations within the heart. And so I think that some of the brainiest and most thoughtful cardiologists I know are electrophysiologists that can figure out all this stuff, understand where all their catheters are, and follow the electrical signal throughout the heart to manage rhythm problems. And it's really astonishing what they can do these days with EP.
Wow.
Bread and butter EP, pacemakers and defibrillators. So these are implantable devices. This is an example this is a pretty old device, but this is something that gets implanted right under the skin, usually here in the left pectoral area. And this wire actually goes into the venous system and down into the heart, and it just lives there. And this is a pulse generator for a pacemaker. And what it does is it detects when the heart is not beating. And if the heart doesn't beat, it gives a little electrical signal and causes the heart to contract. Pretty simple concept, and pretty effective at reestablishing rhythm in people that don't have one for one reason or another. And then the last thing I've got on my list here is heart transplantation. So this is one of the organs in the body that we can replace. And so if your heart is bad enough for one reason or another, and you're fortunate to have a matching donor, you can actually have your heart transplanted with someone else's. And this is a very advanced field of study, another subspecialty area that you have to get specific training in. It's a whole other world of cardiology. But literally, grants a new lease on life for some people.
All right, I think I have to debunk something. Someone said, I remember when I interned at a cadaver clinic and we used to have to remove the pacemakers from the hearts and put them in a box to be reused. Reused in third world countries? Not in this country.
Yeah. All right. So I would say that has been done. It has been studied. I can't comment as to how common that is actually being done. But I do know, at least as recently as when I was in medical school, that was basically never done. But there have been some there has been some interest in that for sure, because a pacemaker defibrillator costs as much as a new car. I mean, it's tens of thousands of dollars, and particularly if there's a long battery life left, yep. You could. We can autoclave and sterilize all kinds of stuff. It's seemingly plausible that you could very much do that.
Yeah.
But it gets really, really complicated because it's like, well, who owns that?
Yeah.
Like if my Blue Cross insurance bought the pacemaker and then I die, do I own it? Does Blue Cross own it? Does my family own it because now I'm dead? Can I put it in my will?
Yep.
It's tricky.
That's weird.
It's tricky. So but it is not commonplace to my knowledge.
Yeah. All right. Should we do some Q&A here?
Yeah, absolutely. I just wanted to mention this last little bit here. So the top 4 on here are the sort of the most common cardiovascular sub-careers. So I'm a non-invasive imaging guy, interventionalist, people that do the stents, electrophysiology, heart failure transplant. But there are some of these other areas that are growing. They don't have their own recognized like subspecialty exams and board certifications and that sort of stuff yet. But there are people that do general cardiology and then they do all prevention, right? And they don't do hardly any of the stuff I talk about. They focus on getting people blood pressure under control, getting them active, that sort of stuff. There are some that want to go the opposite end and they do cardiac intensive care. And that's what they want to do all the time. But anyway, so there's a lot of very interesting subspecialties to get into within cardiology.
Awesome. Well, thank you for that. Lots of great information. If you want to actually, I can do it for you. Turn the screen share off. And we got some students here. We'll go one by one. Saloni.
Hi, can you hear me?
Hello, I can hear you. Can you hear her, David?
Yes.
All right.
Hi, it is very nice to hear about what you do. That was very enlightening. My question was, as a doctor, do you devote any time to research, or do you know any of your colleagues that do? And how much time out of the year would you do something like that?
Yeah, so I actually do a lot of research personally, and it depends on how much funding I have, how much I actually get done. So when I first started my career, I had no funding, and so I just sort of had to shoestring my own research together. So I did a lot of stuff sort of on the margins, evenings, weekends, that kind of stuff, trying to get residents, fellow students, other people to help me out to get some stuff off the ground. I eventually got a grant that covered 75% of my time to do research. So then I was only doing clinical work about a quarter of my time. And now that's kind of shifting back. I've actually got some new jobs that I've been taking on lately that have me doing a little bit less research. But yeah, so I do quite a fair amount of research. Me personally, I do what's called health services research or outcomes research. So I am not really, I don't have a mouse lab. I don't have a liquid chromatograph or any of that kind of stuff. Like I have a small office size of a closet in a hospital, and I am looking at things like I was talking about before, where how much is COVID affecting heart failure admissions, right? So I can do that just by looking at the data that's captured in the medical records. But that's predominantly the kind of research that I do.
Thank you so much.
Right.
Sure.
Thank you. All right. Ish. 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 Hello.
How's it going?
It's good.
Hi, doctor. So I'm actually a heart transplant recipient.
Oh, congratulations.
Yeah. Thank you. So I had some questions about that. So there's different types of exercise that they've done research for. Do you think that high intensity training would be the best for cardiovascular health or weight training?
So actually, funny you should ask, because I just answered that question for a patient. That was like the last question I answered of the day today.
Look at that.
Disclaimer: this is not personal health advice.
I'm relating. I'm relating the anecdote for the patient that I talked about today, who is not a heart transplant patient, but was a recent bypass patient. And what my understanding of the literature, noting that it's not something that I've done a real deep dive on, is that basically the more you can do, the better you are. Right. And so it's kind of like splitting hairs when you talk about weightlifting versus a HIIT or whatever else. Consistently, study after study after study after study has shown that if you're capable of doing more, you are likely to live longer, with or without heart disease, with or without other chronic illnesses, with or without diabetes. So that's what I try and get my patients to focus on. Now, admittedly, my patients are not asking me these questions for the most part. Most of the patients that I'm seeing are completely sedentary, right, and I'm trying to get them to do anything. That's mostly what I focus on. There are some people that are more expert in athletic heart disease that may know more detail about that literature. I would say that in general, aerobics is probably more healthy for the heart than weight training. But I'll also tell you what I personally do is my dumbbells are over there.
I see that both legs.
My dumbbells are over there. My yoga mat is in the corner, and my exercise bike is out in the garage.
Nice.
So I do a little bit of everything. But that's also, I'm interested in not only maintaining my cardiovascular health, but my bone strength, my flexibility, not being injured in another musculoskeletal way. So I think that's another important thing to keep in mind as well, is keep a holistic approach. And it's not all about cardiovascular disease, says the cardiologist.
Awesome. Thank you. So David, what you're saying is contrary to what I've heard before. The heart doesn't have a set number of beats, and you're not going to use them up faster if you exercise.
No, it turns out I was reviewing one of my prevention talks in putting this together, and there was this provocative editorial in The Lancet from a number of years back that tried to estimate how much global mortality is due to inactivity.
Yeah.
And their estimate was that it was about 9%.
Wow.
That just inactivity alone, just not being, just not getting off the couch is enough to kill 9% of the population of the world. So, that's where we're at.
Manuel.
Perfect. Thank you for being here today, first of all. And my question was along the lines of the fact that you mentioned that you research outcomes. And I wanted to see what was your opinion on the contribution of dietary cholesterol to heart disease, because I do find that at least to the public, to the general population, cardiology seems to be at least somewhat contentious in the media. And I wanted to see what you thought was your contribution of particularly to cholesterol, and whether it is how efficacious is a biomarker? Is it cholesterol, or is it a transporter of cholesterol? And kind of your thoughts on that end.
Yeah, this is another one where there's sort of like a 30,000 foot view answer, and then there's like super down in the weeds. And I would say that for me, what am I primarily concerned about with my patients? It's their LDL, their low density lipoprotein. And there is a lot of debate as to how much of your LDL is due to your diet, how much of it is due to your genetic profile, how much of it is due to your activity profile, your diet, your dietary choices. There's a bunch of different things that contribute to it. How much each one of those plays a role has been difficult to pin down. The diet part, I think, is one of the toughest for a couple of reasons. And I would say this, my opinion. Anytime you hear a diet study in the lay press, you should take it with a grain of salt. Because think about the logistics of conducting a trial. And if you've never done this, one of the things that you have to figure out is what's the design of the trial. The vast majority of dietary studies are what we call cohort studies, where basically they find 10,000 people and either ask them up front, keep a track of every single thing you eat, or worse, for the last 10 years, what have you eaten?
I can't remember what I had for breakfast.
But that's what they do. I mean, that's how some of these studies are conducted. And so if particularly any study that uses that kind of methodology, like it's just forget it. I throw it out the window. It's garbage. If they have somebody keeping a food diary going forward, it might be better, but people lie. People
are very aspirational.
Well, there's that too. Yeah. I mean, yeah. So I'm kind of doing an end around here to undermine undermine these things in general. These diet studies are really, really tough to know how valuable they really are. There is a compelling argument to be made that a vegan diet probably substantially reduces your risk of cardiovascular disease. And if you're interested in learning more about that, I would encourage you to look up a physician out of Chicago. His name is Kim Williams. I forget his Twitter handle. But he is one of the leading experts from what I can tell on how a vegan diet can substantially reduce your cardiovascular risk. And he's given a few talks that I'm pretty sure are available, publicly on YouTube or what have you, where you can get an idea of it. And then the other part of lipids is that there's a whole subset. There's an entire board certification just in lipids that you can dig into a million different subfractions of the lipid profile and these transport particles that you were talking about, and you can go really, really, really deep. But again, my patient profiles, these are people where like their LDL is 200, and I'm just doing my best to get it down to under 100. Under 70 would be great if I can get it to there through whatever combination of diet, exercise, and drugs that I can. But yeah, so for me, that's the environment that I operate in. I do believe dietary cholesterol has a component. I think it's probably not. Yeah, I'm finally answering your question. I do think it has a component. I don't think it's as strong as genetics, or as how much your body can handle cholesterol if you're physically active and those sorts of things. And then, I mean, if we look at the statin medication class, and then the newest, they're called PCSK9 inhibitors that dramatically lower LDL, and they reduce events consistently. So, I mean, the medications help. They help too, for sure.
Nice. Thanks, Manuel. Danielle Bellardo is another great.
Oh, yes. Danielle's great. Yes.
Cardiologist who's.
I totally forgot her, but yeah, you definitely follow her.
Yeah. She's up to like almost 200,000 followers on Instagram.
She's good.
Spreading her knowledge. Yeah.
Mm-hmm. Yeah, she really knows her stuff. So,
Issa.
Are y'all able to hear me?
Yep.
Yep.
Okay. So I just want to preface by saying I wish I could turn my mic on, but this computer doesn't have a mic. I want to ask a little bit of like a back to your roots sort of question, doctor. It has a little less to do with cardiology and whatnot. It's a two-part question. Feel free to answer as briefly as you want. I know a lot of time has passed here. The first part is I'm a pre-med. In about 2 months, I take my MCAT. There's a lot of stigma amongst a bunch of pre-meds that you waste your youth in medical school. And I've seen so many bright minds who I consider even greater than myself or, on my level, whatever. I'm doing pretty well. I'm not trying to brag. But they've turned away because they've heard, oh, I'm going to waste my youth. I'm going to go do something else that takes less time. So the first question is, what was your thought process of being pre-med and going into medical school about your time in youth that a lot of people are living it up or whatever? And the second part is going to be outside of medical school when you graduated and you became a cardiologist. Do you have time to live a normal life with like a family and not be rushed? Because that's the other part of the stigma. There's two halves of it.
Yeah, no, those are great questions. The first part is pretty easy. Medical school was still fun. I had great friends in medical school. We went out.
Some of my best friends still.
Yeah, absolutely. Yeah. Absolutely. Fun is where you're at, right? Fun is a state of mind. Fun is, I don't know. So I understand the criticism. It never really crossed my mind. I was driven towards medicine at such an early time. I was just like, yeah, that's what I want to do. So that didn't really, that was not a question that I grappled with a whole lot. But my medical school was tons of fun.
Yeah. It's hard, right? It's hard and you're busy, but it's a blast. Yeah.
I mean, but seriously, it's like, okay, so, what's the alternative? I graduate from college. Let's say you're lucky and you get a great job that you're super busy right up front. Yeah. And you're working, 40, 50, 60, 70 hours a week.
Yeah.
You hopefully, have some friends that you make at your work and you're going to be able to go out and have fun with them too. But I think that, that depends a lot on the situation. Maybe that works out, maybe that doesn't. I've heard, I've got friends and family that did that sort of thing and they're not very happy with where they're at in life now. Not to say that if they had gone to med school, things would have been better. I think it's just hard to predict. But the other thing for me is that I'm 10 years into being on faculty now, and I'm actually teaching first and second year medical students. And they're in great spirits, even with COVID. They're still finding ways to be friends with each other and have fun and, do their best to be social in a safe way.
Not like the residents at Shands who all got together and partied. Not
just one part. It was just anesthesia. It wasn't cardiology. And I'm pretty sure they got highly reprimanded because I've heard the stories. I had a great time in medical school. I don't feel like I wasted my youth at all.
The opposite is regret, right? Is well, I don't want to spend all my time doing that, so I'm going to do something easier, shorter, etc. And 10 years down the line, you're not happy, always questioning, what if? No, thank you.
Yeah, and it's you can't predict it. You can't predict. You could get in. You absolutely could get into medical school. I had another student that I worked with who spent a lot of time debating whether or not it was what he wanted to do. And he went to all the trouble of getting into medical school, and then he took a year off after first semester of his first year. He's like, I got to take a break and think about this, and then they let him come back, and then he continued to struggle with it for the next 2 years, and he's sticking with it right now. But that's something that he's struggling with, and it's hard. I have plenty of time for family. I put my kids to bed right before coming in. I've got 8-year-old twins. We just had a what I consider to be a COVID safe trip over Christmas break, we went up to a cabin in Tennessee, and I took a week off and just went up there. One of my coworkers across the street did something similar and is gone for a couple of weeks. Like, we have vacation, we take vacation. You can work as much or as little as you want to as a doctor. If you want to work 90 hours a week and never see your family, and pull down 7 figures, you can do that. You probably won't have much time to spend any of those 7 figures. If you are okay not working as hard, you'll have time for family. I know people that operated both ends of those extremes.
Awesome. Great question. Thank you. Last question, Shane, you're up. Hello,
Hi,
Shane.
thank you. Hopefully this is quick. So you kind of talked about how, heart disease is kind of being seen as like a new preventable thing. I was wondering, how that kind of plays into the future of cardiology. Like, do you see heart disease getting fixed in the next 10, 20 years, or any new diseases coming out or new medications for management? What's the future of cardiology to you?
Yeah. Great question. There's another slide from my prevention talk that I didn't get a chance to show you, but actually shows the prevalence of cardiovascular death and how it's steadily increased through the 50s, 60s, 70s. And then actually, as we got better control of things, people stopped smoking, we started to see a decline. And we actually have made some headway. But it's kind of one of those things that you hope, like, that means you're winning, right? Yeah, it means you're making a difference. And so as a cardiovascular care community, yeah, we're making some headway. We got a long, long, long way to go. It's not being prevented. It's not going to be eliminated anytime soon. Because the other slide that I have, I mentioned how people have poor control of their blood pressure, but the obesity epidemic is contributing to this and blunting some of the inroads we were making. There's still plenty of people that smoke. There's a lot of high cholesterol out there. I think that one of the things we're seeing a lot more of and appreciating a lot more is something called familial hypercholesterolemia, where people actually do really have it run in their families, and they get heart attacks at age 30, age 40. And it's just, it's sad to see. There's a lot left to understand. And then we've got entire areas that I didn't even have a chance to touch on. I talked about blockages in the coronaries, which you can actually see and then put a little piece of metal in there and open it back up. There's a whole other, branching of the tree of the coronary arteries into these arterioles and the capillaries and much, much smaller vessels. They can all go wrong too. And we are just now beginning to understand how much that portion of the cardiovascular system contributes to the bigger picture things like heart failure and high blood pressure and heart attacks and that sort of stuff. And it's not small. There's a lot in there that we still have to, there's so much we don't know. And so for all that we know, there is a ton left to understand. And then just to sort of, close the loop, I guess, is that the reason I'm interested in this health services research kind of approach is because while the newest and latest drugs and diagnostic techniques and all those sorts of things are really fascinating, we don't own our house. We don't have control of blood pressure. We don't have control of physical activity. We don't have control of these things that we know work. And so I'm more interested in trying to rise that tide, raise all the boats, rather than, because not to dismiss it. The other stuff is great. And somebody's got a passion for developing the newest and latest drugs. Super, go out and do it. It's not my passion. It's not what I'm in. Not my primary focus.
Thank you.
Thanks, Shane. Dr. David Winchester, thanks for spending a couple extra minutes with us tonight.
No problem.
Hopefully lots of students got a lot of great information, shed some light on the field of cardiology to make it even more competitive in the future.
If they want to do it, bring them on.
I appreciate you spending your Monday night with us. Go Gators. Have a great night. Thank you again.
All right. Have a good one.
Bye, everyone.